Do you have it now?
Not yet. Did you send it to nhs.net?
Yes, I did.
No email yet.
Can you please refresh?
Yes, I'm trying to refresh it.
Can you see? I'm trying to share.
Now I'm sharing my screen and I will open
Okay.
your. Can you see it?
Yes, are you on water cartes?
Yes.
No.
And the first page with Curti and your name.
Oh, okay. 1 minute. I can see. Yes. Okay. Thank you. Thank you very much. Okay. So can we go to the next slide, please? Right. So we're going to be talking about CAR-Ts this morning using these following outlines. Next slide, please. Next slide. Okay, so we CAR-Ts are chimeric antigen receptor T-cell therapy. It's a relatively new treatment used in the treatment of malignancies, particularly hematologic malignancies. It's got widespread approval and use in the United States and in the UK. UK was actually the first European country to start CAR-Ts, and it was first approved for use in UK in January 2019. Initially, it was approved by the FDA in 2017 autumn, and the first product to approve was Antigen for treatment in childhood and young adults B-cell acute lymphoblastic leukemia. So they have core designer therapies, being that they are used they are genetically modified T cells. What it does is it uses the patient's own T cells are harvested and then genetically modified in the laboratory. We have certain manufacturers that produces it, and it's not a off-the-shelf treatment. It's individualized to each patient. So you get the patient T cells, re-engineer it in the lab, and then re-infuse it. What's done in the lab is that you introduce a chimeric T cell receptor that is able to recognize a specific cancer protein. In this case, in lymphomas, in this case, the targeted antibody is the CD19, which is common on all B-cell malignancies. And so it's able to recognize this CD19, that's the outer fragment of the antibody is on the CAR. And then you have an intracellular, a transmembrane, and intracellular membrane that activates the T cells independent of MHC or HLA system, and is able to, stimulate, and expand the T cells. So we have here we have the extracellular domain, which is the antibody fragment that can recognize the targeted antigen, usually anti-CD19 for B-cell malignancies, and also it's also used in myelomas, and in myelomas it's targeted against B-cell maturation antigens. That would be the extracellular part of it. And then the intracellular or the T-cell part is just to stimulate, activate, and expand the T-cells to be able to, so you sort of have an exaggerated activity of what T-cells are naturally supposed to do. Next slide, please. So the whole process is from of CAR-Ts is where you get the patient goes through leukapheresis, where you collect lymphocytes. The T cells are separated from the lymphocytes, and then they're taken to the laboratory. They're frozen and transferred to the manufacturing plants, where a CAR construct is inserted using a viral vector. Usually, it's a lentivirus, a retrovirus that is used to, you transfer the CAR into the T cells and re-engineer it to express this CAR antigen on their surfaces, and then you expand it in vitro, and it's returned back to the patient where activation occurs. Usually, when you are re-engineering this, usually you have a co-stimulatory domain that, depending on the particular CAR-T product that you're using, you said they're going to have the 41BB for the T-cell or the CD28, which prolongs, which expansion and then longevity of the CAR-T cells. They can actually last for months to years. And so it naturally the CAR-T, the T cells would usually activate and then die very shortly. But because they've been re-engineered, they have longevity. They have anti-apoptotic use and they have longevity, and they can stay for months and months. So they continue to act and work as long as they are in the system of the patient. Obviously, this also comes with some side effect because it's like you have an immune response that is just left open and it's ongoing, not so you've removed sort of like the natural regulatory systems to that, and that's what mostly causes the side effects associated with the CAR-Ts. Next slide, please. So this is what we have first generation CAR-Ts, which has just the stimulatory domains, and then the second generation has a co-stimulatory domain, which sort of just preserves its longevity. And this is that the available CAR-T products now are the second generation, but now we have third generation. We have hammered CARs. They have it's just ongoing. They're trying to add different things, had a checkpoint to switch off the CAR-Ts and all of that, but those are still in trials. But the one in use now is the second generation CARs. Next slide, please. So this does just show what happens after you have when you've infused your CAR-Ts back into the patient. So you have the expansion of the CAR-Ts. You have rapid expansion into millions, depending on the tumor burden really, and then persistence after the infusion. And this sort of, you can sort of correlate it with the response, the treatment response of the patient and the side effect that the patient has had. Usually you can check for the CAR-Ts using flow cytometry to check how long they are still in the system, and it's been found that they are actually detectable CAR-Ts even after a year of infusion in some patients. Next slide, please. So these are the licensed CAR-T products in the UK at the moment. We have the acicaptagene lysoleucel, which is also called Axicel or Yescarta. This is manufactured by Kite, and it has a CD28 as its co-stimulatory domain. It is approved for both second line and third line indications for diffuse large B-cell lymphoma and other high-grade B-cell lymphomas. We'll talk about that a bit later. And then we have the Brexucel or Tecartus, which is also made by the same, it's manufactured by the same company. It has the same co-stimulatory domain, but there's been a difference in manufacturing that ensures that the cells don't get activated in vitro, because it now is useful in mantle cell lymphomas, and more recently it's now been approved for treatment in adults with ALL greater over 26 years old with a relapsed and refractory ALL. And then we have a Tisagen, which has a 4-1BB co-stimulatory domain, and this co-stimulatory domain sort of affects the way they behave in vivo. And most people with the Tisagen is found to have it has lesser toxicity, but it's also believed not to be as it's not been found to be as useful as the other ones. So initially it was approved for third line diffuse large B-cell lymphomas, but now that the approval has been removed in the NHS, but it's only used in children and young adults up to the age of 25 for BAL. Next slide, please. So for second line, initially at approval, it was usually used for third line, but now in recent times, in the last 1 year, 18 months now, we've had it's now been approved for second line therapy in patients with high-grade B-cell lymphoma who relapse within 12 months of completing the first line of chemoimmunotherapy, and who would otherwise be eligible for potential stem cell transplantation. These are actually very strict criteria, so you must know this. They are quite strict. The patient must be fit for autografts, and they must have relapsed within 12 months to qualify for the second line therapy. It's still under the CTF, so you have to get a CTF approval for second line. And the patient must, all patients who are refractory to first line chemoimmunotherapy. It's second line treatment are not used for bucket lymphoma, primary mediastinal B-cell lymphoma, primary CNS lymphoma, or patient who's had a Richter's transformation. Despite this strict criteria, holding therapy is allowed. What I mean by holding therapy is if you've had the standard first line treatment, but obviously you can see that this patient isn't responding very well, and you already had a plan to refer to second line CAR-Ts, because CAR-Ts take a long time to get manufactured. It's a long process. It's not something you can just do within a week. So you're allowed to give a maximum of 2 holding therapy cycles, which would be your standard sort of salvage therapy. But this is like a salvage therapy or second line therapy being given with the intention that this patient is going for second line. Patient's already been identified, it's already been referred, but you're trying to hold the disease from progressing whilst the CAR-Ts are being gotten ready. So that's what the holding therapy is in the context of the second line. Can we go to the next slide? Next slide, please. And this third line therapy, it's now commonly used. It's for patients who are relapsed or are refractory after 2 or more systemic therapy, standard line therapy for diffuse large B-cell lymphoma, primary mediastinal B-cell, transformed follicular lymphomas. Also, Tecartus for treating mantle cell lymphoma is also used as a third line treatment, where patient must have had 2 or more lines of systemic therapy for standard therapy for mantle cell lymphoma, including ibrutinib. So patient must have had BTK inhibitors and failed before they can be referred for third line CAR-Ts as mantle cell lymphoma. And also you have Tisagen for treatment of children and young adults. And also Tecartus also being used for B-cell lymphoma, for BAL, who have relapsed or refractory after 2 or more standard line of care. Next slide, please. Yeah, I've just tried to define refractory disease and relapse disease as per the national panel, but I suppose this is probably something that we are all used to. So refractory disease will be if you have the progressive disease as the best response to your first line standard treatment after at least 2 cycles of chemoimmunotherapy, or stable disease as the best response after 4 cycles, or a partial response as best response after 6 cycles of the first line, or you have a partial response with biopsy-proven progressive disease within 12 months or less from completion of treatment. And relapse is also when you have disease which was initially in complete remission following first-line therapy and has now been followed by a biopsy-proven disease within 12 months or less from completion of your standard line of treatment. Progressive disease usually would need to be defined radiologically. An acceptable standard first line would be anthracycline containing regimen, including R-CHOP, polar R-CHIP, R-Codoxem, or R-Rival combination. And patient must be fit, physically fit, with usually ECOG 1, 0 to 1 at apheresis and up to ECOG 2 at infusion. Next slide, please. Okay, patient selection. We have, I'm sorry, that slide is quite small, but I've just included an algorithm to show usually what would we would expect to happen. Usually the CAR-T centers, there are quite a few CAR-T centers in the UK, but they are scattered around the whole country. So there would be a catchment area for each CAR-T center, and the plan is for each center, each hospital to have a good relationship with the CAR-T center servicing their own hospital, such that when you have a new patient with high-grade lymphoma or ALL, and you already have, you think this patient might be high risk or might not respond properly, that is the point where we expect you to start discussions with the CAR-T center. So the patient selection, patient will be identified at their local hospital and discussed with the CAR-T centers. This usually would happen during maybe, after you've had during your first line treatment. Usually most centers, I believe, would do a PET, a scan, an interval scan, maybe after 3 months of therapy for lymphomas. And if at that point you're thinking the response is not very good, even though you want to continue the first line, but at that point you start thinking of alternative therapies, and CAR-Ts will come into this line of alternative therapy. So at that point, you start, you look at the patient, if patient is eligible for second line or third line, and then you discuss with your CAR-T center. And following discussion and maybe advice, the patient gets formally referred. There's a national CAR-T panel, and there's a form that you're supposed to fill to refer the patient to the CAR-T center. At the point of referral, the forms usually will contain details of their prior treatment, the initial biopsy report at diagnosis, if you've had further biopsies, comorbidities of the patient to assess with their fitness. And these are all looked at the referral center. There's a regional MDT where discussion happens about each and all patients, and then the patient gets referred to the national CAR-T panel, who are the ones that would give approval whether the patient can go ahead with, excuse me, with treatment or not. All patients has to go through this process. Sometimes there might be some pre-approved patients, particularly for third line at the national panel, but they all still get routinely referred to the national panel. Stop. Next slide, please. Okay, so this is the pathway. So we've talked about referral to the CAR-T centers. It's discussed at national panel and approved. At the CAR-T, regional CAR-T centers, the patient has seen, eligibility has been determined, and there is a plan which starts with apheresis, sometimes depending on the fitness, the disease burden of the patient. Some patients may require more treatment before they are ready to go for apheresis. Please note that most of these patients will be patients who has quite a rapidly growing aggressive diseases, so it's you have to be on top of it at every point in time, and this has to be done in collaboration with the referring center, because they might need their very treatment organized at very quick. You need to be on top of things and just get on with treatment at each point. So if patient needs some treatment before apheresis, then that needs to be arranged. Usually it's done in the referring center, just to make sure the patient gets the patient to apheresis, and then once apheresis is done, it's sent to the manufacturing. It's frozen usually at the NHSBT and sent to the manufacturing centers. It depends on who is manufacturing. For most of Kite products, they will collect immediately. For Novartis does Tisagen. They would it will be frozen in NHSBT and they collect after a day or two and transfer it. All the manufacturing centers aren't in the UK, so they are usually transferred to their manufacturing centers either in Europe or America for manufacturing. And this takes roughly about 3 to 4 weeks. Now it's because with experience and this is about 5 or 6 years of CAR-Ts in the UK, so it's turnaround time is slightly shorter now. Whilst you're waiting for your CAR-Ts to be manufactured, most patients will get bridging therapy. Bridging therapy is to bridge them to CAR-T infusions, and it's been found that if you've looked at any of the trials, the CAR-T trials, a lot of them didn't use bridging therapy, but it's actually been found that people who had bridging tends to do better with CAR-Ts, largely because you're reducing the tumor burden. You're trying to also get the patient to be physically more fit, and you're reducing their risk of adverse side effects when their disease burden are quite low. The toxicity profile is slightly better. So almost everybody gets bridging therapy, which is going to be determined by the CAR-T center. Usually it would be, it could either be chemotherapy or radiotherapy, depending on where the disease is. If it's localized, you can use radiotherapy, or you might just go for systemic chemotherapy if it's more systemic. And then once the CAR-T cells are ready, the manufacturing centers advises us of timelines to delivery, and then we can go ahead with lymphodepletion chemotherapy, which usually would happen in the CAR-T center. It's usually done in the day unit, so patient doesn't need to be admitted in the hospital for days. Lymphodepletion is usually done. Sorry, I can see a question popping up. I haven't mentioned bendamustine. I'm not sure what the question was about.
We will have question answer session in the end. So.
Okay. All right. Okay. Right. So lymphodepletion, usually we use fludarabine, cyclophosphamide lymphodepletion. This is done from day -5, and then you have 1 or 2 resting day in between, depending on the disease. And then you have CAR-T infusion, which happens in hospital. Patient is admitted for infusion. And usually, ideally, the UK recommends 10 to 14 days inpatient stay. We at least we keep them for 14 days. This is because that's when you have the highest chance of having the side effects following CAR-Ts, and then they are discharged to their homes, or if they live more than 30 minutes away from the hospital, they can get into an apartment close to the hospital. That so we can have they have easy access to the CAR-T center if they were to have any issues within the first 4 weeks of their CAR-Ts. So after the end of the 4 weeks, they are then discharged back to their local referral centers. And at that point on, we share care with the local referral centers up to 1 year when they are discharged from CAR-T services itself. At every point in time, there's a disease assessment going on. Usually, depending on the disease, you're either going to be having PET scans, PET CT, bone marrow, aspiration, and biopsy. And we do it at specific timelines, usually at day 28, day 100, 6 months post CAR-Ts to assess for remission. Next slide, please. Okay, so yeah, this is a sort of a repetition of everything we've said already. The initial workup is the assessing for fitness, referring to national, regional, national panels, apheresis. Then you bridge to CAR-Ts, and then conditioning to prepare. The conditioning is essentially to sort of clear the body of the natural T cells, so you have enough space for your CAR-Ts to be able to expand without any interaction from the patient's own immune system. So the CAR-Ts are able to, expand and then attack the cancer cells. And then the CAR-T infusions. Usually CAR-Ts are usually supposed they are infused within 48 hours of conditioning. However, in cases where you have no choice, it can be delayed for up to 14 days after conditioning. But anything more than this, you would have to recondition the patient, which we try to avoid. And then the early follow-up period mostly is to just look out for the side effects associated with CAR-Ts. And then the long-term follow-up also is to look at long-term side effects of CAR-Ts. Next slide, please. So the early complications following CAR-Ts are usually cytokine release syndrome, neurotoxicity, which is immune effector cell associated neurotoxicity syndrome, neutropenic sepsis. They could have tumor lysis, macrophage activation, and HLH-like syndromes. And this usually would happen early. And more later complications is they have prolonged cytopenias, B-cell aplasia, hypogammaglobulinemia, atypical infections following this. Next slide. So to look at CAR-T cell toxicity, the common ones or the more important ones, particularly in the early stages, we did the cytokine release syndrome, the immune cell associated neurotoxicity, and then sometimes they might be prone to HLH or macrophage associated activation syndrome, which have specific grading systems for them, and then you manage according to these grades of toxicity. Next slide, please. So cytokine release syndrome, it's sort of like a sepsis-like syndrome, which is caused by massive activation and release of cytokines by the CAR-T cells. Because of the massive activation of the CAR-T cells, they release lots of cytokines following a CAR-T infusion, and this can lead to reversible organ dysfunction. Usually, it's severe in about 10 to 30% of patients who's had CAR-Ts. The median onset is about day 2. And it's more common in access more than T-cell. And because of this, you do have to monitor the CRS score very closely, at least a minimum of 2 times a day. But usually we would monitor at least 3 times in a day when they do the normal observations for the patient when they are inpatient. They also check the CRS scoring, and then you're able to manage appropriately. CRS it's a sepsis-like syndrome, so it can basically affect every and all organs. You have hematologic abnormalities. They have the deranged LFTs, they could have coagulopathy, they could have electrolyte derangement, they could have basically everything can go wrong, renal impairment and all of that. Next slide, please. So usually, even though the median onset about day 2 usually can occur within the first 10 days, it could overlap with HLH and macrophage activation, and it always presents with fever. So usually you can't actually make an assessment of a cytokine release syndrome without fever. So there would always be fever, and according to the ASBMT consensus, this is now the grading system we use for CRS. We have grade 1, which is temperature greater than 38 degrees. Then grade 2 is other than temperature of greater than 38 degrees. If you have hypotension requiring fluid responsive, hypotension responsive to fluid boluses and not requiring vasopressors, or hypoxia, which responds to low flow oxygen. Usually that's oxygen between 4 to 6 liters by nasal cannula will be required as low flow oxygen. If it doesn't respond to, if hypotension and hypoxia doesn't respond to fluid or low flow oxygen, you needed vasopressors or you needed high flow oxygen, then that is grade 3. And grade 4 is when you need more than one vasopressors and you need maybe invasive ventilation and ICU care. That will be grade 4. Now, please note that after grade 1, you, irrespective of fever, if you have hypotension or hypoxia, that will be grade 2. If you have hypotension or hypoxia, it doesn't have to be both of them. It's either or. If you have hypotension alone, that will still be grade 2, or you have hypoxia alone, that will still be grade 2. And then grade 3, if they are not responsive to those initial measures like fluid boluses, low flow oxygen, and all of that, that will be grade 3. And grade 4 obviously is its patient is quite ill and you need invasive ventilation, or you are now vasopressors more than one. Next slide, please. So this is a slide to show the cytokines that are released after CAR-T treatment, and you can see the way it's peaked, and this is usually what causes all of the side effects following CAR-Ts. Next slide, please. So this is a table of CRS management according to the grading, according to the score that they have. So if you have a grade 1 CRS, usually what's required mostly is supportive care, and obviously if you have fever in a patient on an hematology ward, you want to do all the infection screening. You give antibiotics as per neutropenic sepsis policy of the hospital. You monitor for fluid balance and electrolytes in balance. You may consider maintenance fluid, but you also have to consider other things before giving maintenance fluid, bearing in mind that most of these patients are patients who's actually been ill for quite a while. So most of them already have a baseline malnourishment, electrolyte imbalance, they have aggressive cancer going on. So you must be very careful so you don't tilt them into fluid overload, which is also something they will be prone to with the CRS and capillary leakages. They are more prone to fluid overload. So you must be careful with fluid balances. Now, tocilizumab is an anti-interleukin 6, which is widely used for cytokine release syndrome. Mostly, it's not implicated at grade 1. However, if you have grade 1 persistent for 3 days, if you have persistent fever, even if you have no hypoxia or hypotension, you will consider giving a single dose of tocilizumab, especially once you've excluded infection. You could, at this point, no steroids are usually given, and then you could also give, obviously you give paracetamol, and if the fever doesn't respond to paracetamol, you can give single dose of ibuprofen, but you must be careful of this also because of associated renal impairment, which they might be prone to following the CRS itself. So for grade 2 CRS, which is when you have hypotension or and hypoxia, so you manage as per grade 1 fluid bolus, and at this point it's important to discuss with ICU. Usually, ideally, these patients are not, they are usually admitted with the ICU knowledge. You have to tell ICU if you're admitting a CAR-T patient because there is a high risk of them needing ICU care as an emergency. So usually we found it helpful to let ICU know when of all the CAR-T patients in the hospital, so they are able to move them immediately if there is any need to do that. And at this point, you consider adding tocilizumab also if they are not responsive to the treatment for hypotension or hypoxia. And if there's no improvement with tocilizumab, you can add a single dose of steroids with tocilizumab or carry on with steroid for about 24 hours. But usually these are things that you must first discuss with the consultant in charge, because we do know that what the steroid does is that they are lympholytic, so they sort of dampen down all the T cells anyway. So we don't want to expose to steroid too early or too much, even though there are now studies that says there hasn't found any difference in the progression-free survival between people who had steroids early and people who didn't have it early. So more people are using more steroids now, but we still like to err on the side of caution and just be not give steroids for everybody. This needs to be carefully considered before you start steroids. Once there's improvement, that sort of everything sort of normalizes or goes back to grade 1, you can stop your tocilizumab and your steroids. And then grade 3, you treat as per grade 2, but for this one you can carry on with tocilizumab. They are allowed to have up to 4 doses at 8 hours interval. And then this for grade 3 or more CRS, they should be managed in the intensive care unit. And then you had steroids at this point every 6 hours, which can also be, the steroids can be, usually we use 10 milligrams 6 hourly, but this can be escalated to 20 milligram, or you can even escalate to methylprednisolone. And once there's improvement, you can taper it off. For grade 4 CRS, next slide, please. You can manage as above, and then usually we give out more steroids. And at this point, you should consider other cytokines like anakinra and ciltuzumab are also now being used. So you could start on anakinra, and you could give anakinra is given at 100 milligrams. You can give up to 400 milligrams a day, which would be 100 milligrams QDS, or even more than this, especially if there is if it's looking like it's tending towards HLH, HLH dose anakinra can be used at this point, which will be almost up to 300 milligram 6 hourly. And then cetuximab, which is also an anti-interleukin 6 receptor, can also be given. This is usually given as a start dose, and but you can repeat a dose after 7 days if there's no improvement or there's need for it. Next slide, please. ICANS. Can I please? I'm not sure I mentioned the dose of tocilizumab. It's usually 8 milligrams per kilogram, and it's given 8 hourly, not more than 4 doses. Next slide. Okay, so ICANS is immune effector cell associated neurotoxicity syndrome. Its pathophysiology is not quite very clearly understood, but it's been thought to be due to increased brain barrier permeability, which allows the influx of cytokines from the blood. And also there's been some local migration of CAR T cells within the CNS, and it's associated with, you have higher levels of cytokine, CRP, interleukin 6, and it's found more commonly in patients who have a high tumor burden. They have elevated LDH at admission at CAR T infusion, and higher CAR T cell expansion. And these people are more likely to develop the more severe neurotoxicity. The higher CAR T cell expansion is obviously related to higher tumor burden, and also the CAR T product has also been implicated. Next slide. So they present with a wide range of neurological activity. Usually, commonly we have dysgraphia, aphasia, confusion, tremors, and it's sort of like it's initially been referred to as cytokine release associated encephalopathy syndrome, but I think ICANS is not the name that most people refer to it as. So in the real world data, the severe ICANS is about 4 to 20%, which is actually quite good, or much better than the CAR T trials at reported. Is a bit lower, so I would think that it might also be due to, we have more experience with managing CAR Ts now, and so the chances of having the severe toxicity, CAR T associated toxicities, are a bit lesser than was reported in the trials originally. About 90% of it would occur concurrently with or just after CRS. So you have patients having high-grade fever and you're managing CRS, and just as they're getting better, then they become tremulous or confused. It's quite rare to see neurotoxicity in a patient who hasn't had a cytokine release syndrome at all. Next slide, please. The median onset is about day 6. And yeah, this is it's okay, just go on to the next slide. So this is what you would expect to see in ICANS. Generally, they might feel a bit dizzy, excessively tired. They might have some headaches. Then they present with altered speech, and then they have movement disorder. They have tremors, they have myoclonus, they have dysgraphia. And those are probably the dysgraphia and the altered speech. They have word finding difficulties. Are some of the earliest things that you would notice. They might be very excessively drowsy, disoriented. They have impaired attention span, agitation, delirium, and in very severe cases, there might be seizures, which can be localized or generalized. They may go into coma. They might have multifocal hemorrhage, cerebral edema, and they could have cortical necrosis. So severe ICANS is associated with really poor prognosis. So this is something we want to look out for really and manage aggressively in CAR T patients. And usually we have a system to monitor, to grade ICANS and manage it. Next slide, please. So I've mentioned a bit of these things that actually affect ICANS. Disease type and disease burden. Usually it's more commonly associated with people with high-grade B-cell lymphomas, with high rapidly growing disease, high disease tumor burden at CAR T infusion. People who've had multiple treatment lines seems to have more severe ICANS also than people who've had just 1 or 2 treatment lines. Usually it's also commoner in the older age group. Then the product specific factors, the CAR design is more commonly associated with accessor than Tesagen. the CAR T cell dose, which which usually it's about the same for most patients, but some people have had to, add a higher dose of CAR T. So if you do have a higher CAR T dose, it's more likely to have more severe ICANS. Then the preconditioning regimen and the product potency, which is essentially the same thing, really. Next slide, please. Okay. There's this app, the American Society for Transplantation and Cellular Therapies. You can download. It's a very useful app, and you can download it on your phone. Particularly if you work with stem cell transplants and CAR Ts, you would find almost all these current systems that you use for all of these patients, ECHO, Seattle score, all those comorbidity index are on the app. And also we have the you can have the CRS grading on this, so you can quickly check on your phone if you are called to see a CAR T patient. And you also have the immune effectors or the ICANS grading system and scoring system also on it. So the ICANS grading, it's we have an I score, which is the immune cell effector scoring system. It's scoring based on from 0 to 10, and you have you checking for orientation. You are asking for orientation to, year, month, city, place, time, place, and that sort of thing. It's grade over 4, so you just supposed to have a pro forma that asks 4 different questions to test their orientation, and that's graded over 4 depending on what the patient can do. You also ask them to recall the ability to recollect things, and you ask to mention the name of objects, regular objects around their room, and that's called over 3. You ask for three things. You can ask for what, show them a pen, a cup, a beaker of water, but that's called over 3, and then you see how much the patient can name things. And then ability to follow command, this is called for a score of 1. Either they can follow it or not. And then your ability to write a previously agreed sentence. Usually at the beginning of the CAR T process, you ask them to write a short sentence, and then subsequently they continue to write it every time this I score is done, and then you can compare if the sentence has changed or not. Usually this could be quite dramatic, from somebody who was writing perfectly well in the morning, and by evening you can't make out anything they are writing at all. So that's also a score of 1. And then you ask them to count backwards from 100 to 0. So most people are able to do this. Even if it takes time, most people will be able to do this. But for people who have neurotoxicity, a lot of them can't manage it at some point. So a total of this is we have a total score of 10. Excuse me. And then you can so depending on what they score, over 10, and this I score is fitted into the ICANS grading. Next slide, please. So once you've had your ICANS score between 0 and 10, then you can insert it into this ICANS grading system, where you have people scoring between I score of 7 to 9. Sorry, I can't hear.
Can you please mute your mics? Can you please mute your mics?
Okay. Thank you. So, okay. So you have if you have an I score between 7 to 9, that would be a grade 1. But you also have to check for their level of consciousness, if they have seizures, if there are any new motor findings, and if you do neuroimaging, if there's any findings on it, that might affect the scoring. So I score of 3 to 6 will be grade 2, 0 to 2 will be a grade 3, and 0 will be grade 4 when the patient is, but this also looks at if the patient awakens spontaneously or not. If the patient is unarousable, that will be a grade 4. If there is a prolonged seizure, status epilepticus, that will be grade 4. And then if you have hemiparesis, paraparesis, and you have any diffuse or focal edema on neuroimaging, would also help you to grade whether it's a grade 3 or grade 4. Next slide, please. Okay, so depending on the grading would also affect your management. So grade 1 usually is supportive care. You would discuss this patient with neurology. You want to start levetiracetam, which is an anti-seizure prophylaxis, usually 750 milligrams, 12 hourly. You start neuro observations, do all the aspiration precautions and assess for swallowing. You could also consider doing a fundoscopy to check for papilledema, which obviously would change the grading of the ICANS in this case. Also, neuroimaging should be done at this point. The MRI is preferred, but if you can't do MRI, you can also do a CT scan just to check for cerebral edema. EEG is also done, which can show subtle seizures, which will also change the grading of the ICANS and subsequently affect the treatment that you would give. Steroids are not necessarily indicated at this point, and tocilizumab is also not needed. For grade 2, you also do manage as per grade 1. Then the neuroimaging EEGs are also quite important to be done. You can do a lumbar puncture, but we found that it's actually quite difficult to do a lumbar puncture in this set of patients because at this point, remember that ICANS usually happens after CRS, which means this is taking them to like the second week of their CAR-Ts. At this point, most of them are quite cytopenic. So you have somebody with a really low platelet, so you might want to be careful with doing a lumbar puncture so you don't cause more harm than benefits. So usually we'll just stick with the neuroimaging. And then if there is a concurrent CRS, that is if the patient still has ongoing CRS, you would give tocilizumab, but as per the CRS protocol. But if there's no concurrent CRS, there's actually no indication for tocilizumab in ICANS because it's actually thought that tocilizumab in ICANS alone without CRS is not helpful and probably would worsen the ICANS because the tocilizumab doesn't clear what's the already, these interleukin 6 that are already in circulation are not affected by the tocilizumab. So we would rather use cetuximab if needed in ICANS because that blocks the receptor. So the interleukin 6 are not able to do cause any troubles even if they does cross the blood-brain barrier. And then you had also steroids. Dexamethasone is preferred. It has better CNS penetration, 10 milligrams QDS. And if there's no improvement usually after 24 hours to 48 hours, you might want to either escalate to methylprednisolone or you would start adding an anakinra and possibly cetuximab if necessary. And for grade 3 or 4, you also manage as above. Next slide, please. It's quite important to just taper off your steroids quite quickly, as obviously we're still a bit weary of just switching off our CAR-Ts completely. So we're quite wary of long-term steroids, even those studies says, well, they don't actually suffer much side effects or doesn't cause any significant reduction in efficacy of the CAR-Ts. So we're using it a bit more now. So obviously for grade 3 and 4, patient needs to be in ICU. They might need to have their ventilation taken over, and you just want to support their respiration and give adequate supportive treatment whilst you're treating the neurotoxicity. Sometimes for the severe neurotoxicity grade 3 and 4, sometimes it takes a really long time to resolve, particularly if the patient has had seizures or is in coma. So this might become a debilitating thing and takes weeks to months to resolve. But for usually the earlier ones, grade 1 and 2, they can actually recover very quickly. Some people have grade 1 and recover very quickly without any treatment at all. But of course, if there's no treatment, you can consider other things to use, including other than siltozumab and anakinra. You could also try etoposide. You can try intrathecal etoposide or consider plasma exchange. Just to you're trying to get out the cytokines that's already in the system. You're trying to wash them out really. And you may need to take advice from the wider CAR-T community if you've done everything possible and you're not having any improvement with refractory ICANS. Next slide, please. Yeah, so I tried to compare the real world data versus the trials outcome, and with time using CAR-Ts in the UK, we found out that the real world outcome are actually a little bit better than the trials outcome, which is a good thing. If you look at the Zuma 1, Zuma 2, and the Juliet trials, which are the major trials for CAR-Ts in diffuse large B-cell mantle cell, and for Tisagen is Juliet. You have all CRS about 93% and grade 3 or more about 13%. If you look at this other, I can't really see it because this is very small for me. But if you look at the toxicity summary, it's from a paper that was published in the British Journal of Hematology in 2020 that's detailed the real world outcomes of CAR-Ts in the UK. You can see that we have a much significantly lower CRS, with all grade CRS being about 88% and grade 3 or more being about 8%, which is significantly better than what the trials have reported. The same thing goes for ICANS also. The real world data shows is actually much lower. And that's a good thing. And we think, well, with experience using CAR-Ts, we found we are able to better manage the toxicities. So that sort of reduce the adverse outcome or effect of the CAR-Ts. Next slide, please. So we talked about management of late toxicities, particularly the cytopenia. So we have CAR-T patients who would we would have a very prolonged cytopenias, and they need to be on growth factors, GCSF, platelet or blood support for a really long period of time. This is very important to let the patient know even from the outset, so they don't have unrealistic expectations. Sometimes we may have late neurotoxicities also, including transient aphasia and seizures. And because of this reason, the patients are usually advised not to drive for at least 2 months after their CAR-Ts. And this is said to the patient at the very beginning, so they are aware of what they are going into. Quite a lot of patients will have B-cell aplasia and hypogammaglobulinemia. So you need to be quite aware of this, because they might come in with atypical infections, and also because of this they are given infection prophylaxis for initially used to be for about 6 months until they have the CD4 is above 200, but now we try to extend it for at least a year. They get antiviral and PGP prophylaxis for at least a year. They may also need antifungal prophylaxis if they have a long-standing neutropenia. And IVIG replacements are also used for patients who has hypogammaglobulinemia and recurrent infections. For patients who's had CAR-Ts, this is you sort of have an automatic approval for IVIG for them. So this is So you need to be aware of that, and you get easy approved. It's pre-approved actually. Also, there is a risk of therapy-related secondary malignancies, although we haven't seen any to date, but it's also always a risk that must be mentioned to the patient, largely because these are patients who's been exposed to several multiple lines of treatment. So the more treatment you have, the more chances you have of secondary malignancies. Next slide, please. So the really important things to know about patient going through CAR-Ts, there must be you must put an alert on this patient if they've had CAR-Ts, largely because of what I've said about atypical infections, late onset neurotoxicities, need for prophylaxis, infection prophylaxis, sometimes seizure prophylaxis. You must also be aware of the prohibited medications. Going into CAR-Ts, these are things that you should know. They're not supposed to have things like steroids, bendamustine and all of that, because they would depress their T cells before they go into apheresis. So if they do have it, there are recommended washout periods for each of these treatments, immunotherapies, rituximab, and you must adhere strictly to this. And their apheresis is booked as per what treatment they've had, their last treatment, and you give enough washout period before you collect this. Otherwise, you're going to have a treatment failure because you can't get any good T cells collected from them. And even there are timelines before apheresis, before lymphodepletion, and before CAR-T infusion itself. And this you should know so you can avoid all of this. Each patient is usually have a individualized plan based on their comorbidities, their tumor burden. We can adjust their treatment plan because we can anticipate what they are going to have. If they're going to have severe neurotoxicity or CRS, and we anticipate and make a plan, an appropriate plan, which is put on the system for them. And this is also liaised with neurology, the ICU care, radiology. All of these people must be aware of the CAR-T patient, so they are able to do certain investigations, procedures, or transfer appropriately to ICU at the point that they actually need it. At admission, you must assess and reassess the patient. Patient with an active infection is a contraindication to CAR-Ts because that will just activate the CRS and give them really severe and bad CRS. So what you must do is to delay the CAR-T infusion and treat the infection first before going into CAR-Ts. Otherwise, you would be exposing the patient to significant CRS risk without any unnecessarily, so to speak. So you can delay it for a few days, like I did say initially, treat the infection, and then reassess the patient and decide when you want to now infuse them or not. So we talked about prophylaxis, going into CAR-Ts and after CAR-Ts, and then you check how long you need to give all of this for. Usually we check their lymphocyte markers, you check their CD4, CD19, CD3 levels at intervals following CAR-Ts, and that may be able to guide your infection prophylaxis. The hematotox score is also a scoring system that is also used for CAR-Ts. This is able to does predict their risk of getting cytopenias post CAR-Ts, and this helps you to adjust the prophylaxis that they need to take and how long they need to take it for. And CAR-Ts it's always a multidisciplinary approach between CAR-T specialists, the disease group specialists, that will be the lymphoma, the myeloma, or the ALL or transplant consultants. They all have to agree. Also, outside of hematology, you must work closely with the dietitians to make sure your patient is fit for a nutrition perspective, physiotherapists from a physical aspect perspective, ICU because you want them to get the intensive care at the time they need it immediately, radiology because of the scans you will need, neurology, renal physicians because they may actually get renal impairment with their CRS. So it's always a multidisciplinary approach within the hospital and even outside the hospital, because sometimes you would have to discuss with people outside of your hospital if you're not getting what your adequate response from the treatment you've had. Next slide, please. Yeah, so I've had a couple of websites that you could check for things about CAR-Ts, how to score the scoring system, the Matrix score, and things you generally need to know about CAR-Ts. Next slide. Okay, so these are the products that are still pending NICE approval. We have a Lysocell for lymphoma. People, this from the published data, it does seem that they've reported lesser side effects, lesser CRS and ICANS than Accessel. And then Obicell for ALL. This actually might be an interesting one because it does, usually the CAR-Ts that we give now, it's a one-off dose, but Obicell has they have the doses of the CAR-Ts are splitted depending on the disease burden, so that the patient it's all in a bit to reduce or dampen down the severity of the side effects following CAR-Ts, which might actually be a good thing. So depending if you have a higher disease burden, you get a smaller dose, like a test dose initially, then in 10 days you get the bigger dose, that sort of thing. If you have a lower tumor burden, they give the bigger dose initially, and then you get the smaller dose after a few days. So, and then for myeloma, we have anito-cell, cilta-cell, ide-cell. They are all in the works for approval. These are CAR-Ts that are already, some of them are FDA approved and in use in the US. But for us, we still are waiting NICE approval. Yeah, I think that is all. Yes, thank you very much. So yes, we can look at questions now if we still have time. Ami, do we still have time?
Dr. Tenny.
Yeah, thank you.
Yes, for the questions, please. So Madiha has asked in the chat section that you have said not for bendamustine bridging. Why is this?
It's for bendamustine is usually because it depresses the T cells quite significantly, and then it takes a really long time. The washout period for bendamustine is about 4 weeks or so. For most patients who need CAR-Ts, their disease probably cannot wait that long to get CAR-Ts. So usually with bendamustine is something sorry, 1 minute. I'm trying to. Wait a minute. Bendamustine bridging is not contraindicated. Actually, I probably must have said bendamustine pre-apheresis. That's what we would talk about, because for bridging, for most of them, actually, the most common bridging we would use would be BR polatuzumab, which would have a bendamustine in it. But that's usually the cause because of the depression in the T cells for quite a while. It's why you do have to be careful about that. But we do use bendamustine for bridging.
Next question is for late side effect. Is it followed at CAR-T center or local center?
Yes. So it is usually a collaboration. When at discharge after 28 days, we usually would send a discharge summary, and the discharge summary would highlight all of the side effects that might happen. so that the local centers are able to know, and they can look out for it, but then they can take advice for us. And if they run into troubles, the patient can always come back to us. But because we do think that it's probably more convenient for the patients to go to their local center, is closer to them. So that's something that can be done at the local center. But we're very happy to collaborate and assist or give advice, particularly maybe when it comes to things that cannot be done at the local center. But I believe that infections can be managed at the local center. But sometimes when they do run into really complex infections, they send them back to us, and we're very happy to take the lead on that.
Okay. Um, whether any mutations that affect your decision regarding CAR-T or not. Like in AML, if we have TP53, then we say that the outcome with the stem cell transplant is very poor. In lymphoma
Yeah.
myeloma, do you have any mutations which will say that, yeah, in this patient we cannot do CAR-T because the outcome is poor?
So to be honest, most of the patients with the poor, the mutations with the poorer prognosis are the ones that would end up not responding to the standard line of care. So they might end up going to CAR-Ts. CAR-Ts usually are for all the people in the high risk stratification groups who may come to CAR-Ts. But the thing is that the prognosis following CAR-Ts may also not be that good. They haven't actually looked at most of the trials haven't looked at different mutations individually, but we do know that people with higher risk mutations also tends not to do great following CAR-Ts, if you get what I mean. So for some people, CAR-Ts now is sort of now like a bridge into, is sort of now, not bridging per se, but if you get what I mean, it's like a bridge to newer treatments. It's a chance at getting to the next treatment that is available, which is a chance we want to take really if the patient is fit enough.
Okay. And when do you advise vaccination after CAR-T cell therapy?
Vaccinations post CAR-Ts is sort of like a same as vaccinations following transplant. So we wouldn't advise any vaccinations in the first 3 months post CAR-Ts because we know that they simply won't be able to mount up any immune response really. But we restart vaccinations after 3 months. So they start with usually the COVID one, which is the one that we're more scared of, because actually CAR-T patients do not do well at all following COVID. And we've had quite a lot of the deaths post CAR-Ts related to infections has been because of viral infections, particularly COVID. So now it's something we do say at 3 months, we start COVID revaccination, and then subsequently they have to get revaccination for all the childhood vaccinations, but that might take up to a year to restart. So yes, it is following the autographed and vaccination schedules, but not earlier than 3 months.
Whether both primary CNS and secondary CNS are the indication for CAR-T, or it is only the primary CNS?
Secondary CNS, if there's no active CNS disease, they can go to CAR-Ts as third line. Yes, they are not allowed in second line treatment. But for third line, if there is no, we do take both primary and secondary, but they would have to be free of CNS disease at the point they must have been treated for the CNS disease and not have any evidence of active or ongoing CNS disease at the point of CAR-Ts.
And for the primary CNS lymphoma, there is no
Yes,
indication of CAR-T.
they could get it in uh you know what, I'm not quite sure. I think it's secondary CNS lymphomas
Okay.
that we do give if there's no active ongoing infection, but I'm not 100% certain, so I can check that and get back to you on it.
And the last question is, What is the timeline of PET scan after CAR-T? Day 20, then day
Day
28 or 100?
28, we have a baseline CAR-Ts. We have a baseline PET scan within the just before lymphodepletion, usually about day -6 to day -10. We expect to do a baseline. That would be after the patient has had whatever bridging therapy they had. So you have a baseline, and then you do one at day 28 that you can compare after CAR-Ts, and then another one at day 100, and then at 6 months. Some people go ahead and do 9 months or 12 months, but usually we, except at 6 months, if things are not still very clear, you may repeat it as indicated.
Oh. Thank you very much, Dr. Tony. This was a very interesting and explanatory session. It should be okay for part 1 and part 2. This was the question that was asked from us for the exam. Thank you very much.
Thank you. You're welcome.
Take care, everyone.